Morning, everyone. Welcome to the meeting. Thanks for everyone joining us online and in person. I'm not going to steal any thunder from Prof. Mochan. You'll see there's a change in program. It's because we have a guest lecture this morning, but let Prof. Mochan introduce him.
Yeah, thanks for letting us squat in your space. But we have a special guest, so he's a Witsi through and through. But he spent the second half, virtually isn't the second half of his career all the way in Adelaide. So he left here 2001, something like that. Yeah, so he was a ad hominem professor of neurology here up to then, and he is PhD, and his main interest is in movement disorders. So he's been running that Parkinson's model, you know, that NPTP toxicity thing here. So he had a whole stable of mice and other animals where you don't normally go. So he was really doing proper stuff. So lots of publications from that. So it's really nice to have him back. So he's visiting at the moment, and he's joining us to just say hi and see the hospital and see the registrars. But he's giving us a talk on his second pet subject, which is basically cognitive functional dementias, and where he's also published a lot. So it's really nice to have you here, Prof. And thanks for speaking. So these are medical people. Be gentle on them. And no, but he's got a really beautiful lecture on cognition ultimately. So over to you, Prof. Thank you.
Thank you, Professor Mochan, and ladies and gentlemen, it's a pleasure to be back here. I spent 25 years here, and a lot has changed, but it's good to see friends. And you say to me, why dementia? And first of all, I am a general physician at heart, and I was telling Andre that I will be definitely meeting the registrars because I wrote a whole manual on neurology in the wards, so the general medicine aspects of all the different diseases with a neurological bent and what is important about it. I must pay tribute to people like Tom Bothwell, who many of you will know about, who taught me clinical medicine, to Harry Reef, who trained me here, and David Marston and Peter Jenner, who supervised my PhD in London, and most recently Bruce Miller in San Francisco, who stimulated my interest in cognition. He asked me to come across to San Francisco because he knew that I was working on the Parkinson's plus syndromes, and he wanted to learn more about, he knew a lot about it, as I found out, but he wanted to learn more and discuss with me progressive supranuclear palsy, or Steele-Richardson syndrome, Alzheimer's syndrome, and the multiple system atrophies, and particularly the cognitive aspect. So I made a deal with him. I said, you give me an office next to you, I'll attend all your ward rounds and learn about frontotemporal dementia, because he was a world authority, still is, on frontotemporal dementia. So we'll get to that in a moment, the non-Alzheimer's dementias. Africa has changed enormously, okay? When I was a medical student, it was unusual for Africa to have ischemic heart disease. We now know, with dietary changes and people living much longer, and HIV under control, well, until Trump came around. But anyway, that's HIV under control, and basically people were living longer and longer. And I took a book out, and I'll give it to the registrars, on African dementia, which deals with countries like Nigeria and Ghana, showing that people are living longer, because this is a disease you'll see of people over the age of 60. So if you don't live to 60, you're not going to see it. Trust me, you are going to see this in your working lifespan. And that's the reason that I'm here and why I'm talking about this. Now, how do I advance this? I'll click on the slide. There we go. Now, before we talk about cognition, we need to understand what cognition is. I think you all understand that memory is part of it, but cognition includes frontal function with executive function, language centers, Wernicke's and Broca's areas, visuospatial and praxis, which is basically the knowledge of where your limb is in space, and motor function, and special senses. So cognition has a lot of domains. Of course, in general medicine, we deal with things that are not degenerative diseases necessarily, the deliriums, toxins, and encephalopathies. So any good general physician will know that there are so-called reversible or treatable causes of dementia, which you don't want to miss. All right? It's no good sending off a whole battery of genes and nonsense. You want to just be sure that you're not dealing with an encephalopathy or something reversible, particularly herpes encephalopathy, which can do really bad things. So what then is dementia? Well, it's a multifaceted generation of cognitive impairment, which I just defined. But it's primarily memory, thinking, attention, and behavior. But the second part of that sentence is that it impairs the ability to perform everyday tasks. So before you diagnose Alzheimer's disease, as compared to amnestic MCI on mild or moderate cognitive impairment, you need for Alzheimer's disease the inability to perform tasks. It affects older adults and clearly increases by age. So if people in populations in Europe and sometimes part of Australia live to 80, 15% of people will have Alzheimer's. And 90% of all dementias are due to Alzheimer's, but there are differentials. We know that diffuse Lewy body disease and the Parkinsonian syndromes and various arteriopathies and frontotemporal dementia, which account for the remaining 10%. So if you're a betting person, 9 times out of 10, if you've got a person that has cognitive impairment with particularly short-term memory loss, you can bet that it's going to be Alzheimer's. But there are red flags that wave that could indicate other diseases as well, particularly in younger patients. So there's the spectrum: Alzheimer's disease, vascular dementias, because it's sometimes multifactorial. Patients with Alzheimer's disease will obviously also have strokes. They may have combined, so those are the 5 commonest diseases. Local in Africa, of course, put them in big letters there: alcohol, HIV, neurosyphilis, tuberculosis, and then all these other things that can masquerade as Alzheimer's disease. All right? So a lot of these other conditions will be very important or more important locally. So where did Alzheimer's disease start? Well, Aldous Alzheimer pathologically described the first case, and I'll show you exactly his case tonight. But before I do that, globally, 25 million people are affected by Alzheimer's. Now, you can probably halve that here in Johannesburg. It's not non-existent, but it may be half that. However, by 2050, we're talking about a projection of 130 million people. So it's more than double. And the politicians are going to start waking up and making sure that there are dementia clinics and geriatric clinics and services to actually look after these people. And if you look at mild cognitive impairment, we're talking about 100 million people. And this is an antecedent for Alzheimer's disease in the vast majority of cases, particularly amnestic mild cognitive impairment. This is from the papers that Alzheimer's, and there was the first lady that ever had this, and there the brain at the top, compared to a normal brain, is what was shown. So see the woman is in a fetal position. Many elderly people in nursing homes will be like this, but in actual fact, this lady had Alzheimer's, and she was relatively young. I forget her age, but I think it was about 65, 70, and that was her brain. And you can see the temporal lobes are completely shrunken away, and more about that in a while. So before I go on to talk about the actual pathophysiology of Alzheimer's, I'm going to take a little bit of a couple next 5, 6 slides and what types of memory we are dealing with. And it's the core feature of Alzheimer's, as I've just mentioned. It started when Wilder Penfield, who was the professor of neurosurgery, for intractable epilepsies, removed part of the temporal lobe. It was the dominant temporal lobe, and there's a very famous patient called HM, which they removed, and it shows you over there. I don't have a pointer, Andre, but anyhow, you can actually see the area that they removed of the dominant temporal lobe. And of course, that contains the hippocampus, which is important. So a very insightful Brenda Miller, who worked in Boston, decided to study this patient because what happened was that this is way before computers, and this is in 1950. So Schofield, the registrar and the student, decided that they were going to get a person with their dominant hand, which is the dotted line at the bottom, and they had to draw between the lines of that stop. And every time they broke the line, they would get the negative point. So with the non-dominant hand as well, there's the top hand, the left hand, the right hand. So when HM came along, they decided with a whole lot of controls, remember the test yesterday? And they said, yes, remember the test, and they did it. And HM said, what test? What are you talking about? Because he couldn't remember, the cap was removed, what test it was. However, he improved exactly, because the scale at the bottom is the number of days and the trials that they went. He improved exactly the same as anybody else in the group that had a normal hippocampus. So what is going on here? What kind of memory was this? And I can give you an example. If you ride a bicycle or if you ice skating, you know, in the beginning you start riding a bicycle and you pedal and the kids get their balance right and the steering right. But after a while, when you know how to ride a bicycle, now wait a bit, you're driving down the road, you're watching the traffic lights, called robots, and you're watching the cars because it's dangerous. But you can wake in the middle of the night and you can pedal your bicycle. So there is a basal ganglia and a structure which contains what they call implicit memory. All right. So all the procedural stuff, the striatum, the neocortex, the limbic system, the amygdala, the cerebellum, and reflex pathway, that's all implicit memory, and that is not the memory we're going to be talking about. On the other hand, there is explicit memory. So implicit memory is the memory that they showed existed, and they didn't even know that that was memory. And we'll come back to recall and tip of the tongue syndrome and why people can have long-term memory, short-circuiting this. But we're talking really about explicit memory for temporal lobe and diencephalon damage. So that was the original diagram. Just to remind you what the hippocampus looks like, well, there's those intersecting C's, and there's a afferent area into the hippocampus and an efferent area out of the hippocampus. And so the CA1, 2, and 3, and basically the alveolus and the various entorhinal cortex, there are afferents coming into that dentate nucleus. The efferents going out of it are the fimbria, and that goes to the mammillary bodies. It's a circuit of Papez. And the mammillary bodies then shoot out towards the frontal lobe to store memory. So, for example, if you have an alcoholic and they destroy their mammillary bodies, then they cut off that's why alcoholics have amnestic problems. And if it's severe alcoholism over a period of time, they destroy their midbrain and parts of it as well. So you know, the hippocampus is crucial to short-term memory. And you can visualize this. You can scan patients, and you can actually measure the area of the entorhinal cortex, the CA1, the subiculum, all the afferent, and that's where plaques and tangles occur, as we will see in a minute. So forget about all the other memories. I'm just putting that out there. We are going to be looking at declarative or explicit memory, and we're talking about memory of facts and events and short-term laying down, which is missing when you miss the hippocampus, particularly the dominant lobe. Right, back to where we were. Now, this is part of the work we did to show that there is a preclinical area that precedes the clinical diagnosis. That bottom blue line on the left is where people are diagnosed. You can see that as you get older, it becomes more common. But remember that there is a lag phase between cell death and for a long time, they've not been able to sort of diagnose and have, but now we do, but now in those days, we knew that there was a cellular damage with the buildup of plaques and tangles and tau, and there was a disconnect between the clinical diagnosis of a number of years. So Brock and his colleagues, and I'll give you the reference later on, showed that in actual fact, their studies showed that large 5 and 6 levels correlate well the pathology with the actual decline in cognition. But again, the early Brock stages, right up at the top over there, paralleled, and we know that there's a cellular problem, and of course, if you're using drugs, the earlier the better, if you can get into that. So what types of Alzheimer's? We're talking about sporadic disease. This is a disease, even if you've got a family history, you may have twice the risk, but it is a sporadic disease called SAD. There are other familial diseases, only 5%, that will have a defect in one of the pre-similants. All right? So obviously, if you've got a person who's got a grandfather, father, it's a dominant transmission, and yourself, and if you're going to use a monoclonal antibody to try and tackle tau, it's no good when the stuff's all laid down. You want to prevent that from happening. More about that in a couple of minutes. Now, why do we miss dementia? The early symptoms are subtle. People are getting older. They're retiring. They lose interest in activities. They lose initiative, and they're forgetful. So what happens here is that, this is just what happens to all of us. Andre, right? As you get too close to 60 and 70, it happens more to us all. But in Alzheimer's, this is happening early, and the spouse will notice repetitions and forgetfulness and much more. So when you get a decline in thinking and problem solving and the inability to perform tasks that you were quite used to doing, then patients start noticing there's a problem. But there's a large gap here in the elderly where this is missed. It's also difficult to define dementia because we've got scales and assessments, and the personality and particularly the long-term memory is preserved. So you talk to a person and their social skills are good, and they remember their teacher at junior school, and they remember you growing up in their early married days, and they talk about all of that. But if you ask them what they had for breakfast or when they last saw you, they'll say, no, the short-term memory is a real problem. And it's precipitated very often, as you clearly understand, where there's bereavement, a loss of the spouse, or there's some kind of intercurrent pneumonia or meningitis. So the diagnosis really includes a good history, a cognitive and functional assessment, brain imaging where possible, particularly functional MRIs and PET scans. Do you have PET scans in CMJAH? I'm sure you do. Blood and CSF analysis is really becoming exciting because there's a correlation between blood tests to tau, certain molecules, and brain imaging. So you could do simple blood tests now and diagnose this quite early on. And of course, if there are genetic tests that are relevant, I emphasize that really 5% of people will have a genetic history. They will have a really strong family history before you waste lots of money on these tests. Well, many of those are not available in Australia, and they've got to be sent to Cambridge and some places. Okay. What are the risk factors? Well, we know advancing age. They say women are more common, but I don't believe that. I think it's equal gender. Down syndrome clearly shows ApoE homozygous state increases the risk. This is not a test that's a blood test that tells you you're going to get Alzheimer's. It's purely a risk factor. The labs have let us down badly, and the researchers have said, oh, if you ApoE, you get Alzheimer's. Oh, it's just no more than a risk factor. And cardiovascular risk factors, an unhealthy lifestyle, that basically means obesity, untreated hypertension, etc. And genetics. The protective things are very interesting. There are certain groups in Europe, I don't know them well, but this is from papers, that show you if you're a carrier, if you live in Iceland or this club group, they have longevity, and they don't know why, and they have much less prevalence of Alzheimer's. Excuse me. We know the different tests. So the mini-mental is the standard test. It's a bedside test. You've got to be very careful how you do this. And the mini-mental examination is probably a part of all papers that come out, which people know so well. The Montreal test is something that was used in Canada, but the best test by far is the Alzheimer's disease assessment in this COG. All right? So there are other assessments and scales, but concentrate on this one because this subscale is a research tool that is very accurate. It takes a lot longer, it takes nearly an hour, but the other thing is the behavioral spectrum. And I won't go through all of this, but if you look at the top 3 diseases, Alzheimer's, Parkinson's, dementia, Lewy bodies, they all have hallucinations and delusions. The non-Alzheimer's dementias, the ones that I used to work with, a lot of them still do, don't have those problems, but they've got disinhibition and they've got impulsiveness. So there's a behavioral spectrum that's very different from the common causes of dementia compared to the non-Alzheimer's dementia group. How long do people live? Well, this is very interesting. The task force, it depends whether you like to live in the United States, or they say 3 or 4 years, that clearly is not right. The European studies looking at thousands of patients mean that from the diagnosis of Alzheimer's, now clearly this is dementia with functional impairment, so it's a clear diagnosis, you may live about 6 years, and that's what I believe at the moment. So you die from Alzheimer's disease. It's becoming so common in Europe that more people die from Alzheimer's than they do from coronary artery disease. Everybody with chest pain gets stented now, and angiograms, and strokes. We dissolve these things with thrombolysis. You know, people live much longer. We treat hypertension, so there's bleeds in the brain, etc. So the degenerative diseases, which has no cure for, all the drugs are palliative and support them, 6 years. Of course, the preclinical stuff before that is at least 12 to 20 years before that. And people who die from motor vehicle accidents and other causes, if they look at the brain without dementia, will see a lot of the dementia changes that they would have developed had they lived longer. How are we doing on time, right? Yeah, I'm halfway. So we're talking about the treatment now. There are no proven cures for Alzheimer's. At the outset, I want to tell you that, because I'm going to discuss all these monoclonal antibodies in a moment. The disease-modifying agents, donepezil, which is Aricept, memantine, which is a DA receptor, a behavioral control with rivastigmine, galantamine, and some of the drugs that are used in behavior in Parkinson's as well. But there's no, this is all supportive stuff and may give you a couple of months. The pharmaceutical industry has, it's not important to know these drugs. In May last year, I made a list. In fact, I had to really update this talk. You'll see in a minute what Nature tells me. But these drugs, they've spent, I don't know how many millions developing these drugs. None of them work. The problem is that they are giving these drugs to people when the diagnosis of Alzheimer's is made. The plaques, the tangles, the tau is all there. What's this going to do? It's just, you know, that's going to come later. It's too late. We want to get the people early on to prevent the beta amyloid from being deposited, to prevent the tau from damaging the cells. And this is just a slide to show you from the top to the bottom with information and the various things insoluble, where these various drugs work. Not important, but there's, and really, Andre, I'll give you this talk and you can circulate it to your registrars. Anybody interested, this is, please feel free to use both the slides and have a look at them in your own time. Okay, so let's look at the biomarkers. And the ones that I'm going to focus now on are the A beta and the tau. Because basically what's happening is there's a neuron, and if you get a neuron damaged in such a way, the tau is a late thing that actually kills the cell. The beta amyloid makes tau much more potent. We'll see why in a minute. So this is the pathogenesis of Alzheimer's. And before we talk about this is what I've been working on in San Francisco for many months, is that there are Block criteria and there are Reagan consensus criteria. All these other studies from the early 1900s have been useful, and they've been built on the CREAG, for example, but these are the ones that we work with today in terms of research tools. And the Reagan criteria takes a certain number of zones of the hippocampus and the neocortex, and they're listed there, and they correlate them with what's called the Brock's score, and I'll talk about Brock's paper now. So the pathological diagnosis really on the Brock's scores is very high when it gets to 5 and 6. It's intermediate at 3 and 4, and low at 1 and 2. And low at 1 and 2 is pathologically there, but it's the preclinical stage. No one diagnosed. We'll see why. So we're talking really about a heterogeneous disorder because sometimes patients have strokes, sometimes patients have other things as well as their Alzheimer's. And of course, the elderly, we know that there's concomitant issues. So Brock very cleverly looked at those areas of what I showed you, the hippocampus earlier on, and he showed the various stages, as you can see there, of Alzheimer's developing. So the bottom right-hand one really is a stain for amyloid specifically, and you can actually see it stained over there compared to the early stages where there's not much in the brain. This is part of our work, and we did coronal sections, and I busted, we learned how to do a brain bank and how to section all these brains. My wife had these things in French, it's quite fun. Anyway, so yeah, she had to be careful which Tupperware she opened. So anyway, the amygdala there you can see, and the hippocampus, you've got to cut the brain in sections because you can miss it. If you're too far forward with the basal ganglia, there's the striatum. Parkinson's yeah, so here's the ventral nucleus. The hippocampus doesn't look too bad. As you start going back here, it's gone. It's just disappeared. Temporal lobes will show the atrophy. And if you look at the neuronal loss, that's just a picture to show you the red zones are really where the white and the red zones are where the cells are 90% gone. So if you look at the literature, where are people writing about these things? Well, A beta and neurotransmitters and lifestyle modification are where it's at. Mitochondrial dysfunction and other things are much less represented. So it's generally an idea of where people are sort of researching today, and that's a really recent slide. And of course, you must remember that the amyloid proteins are Alzheimer's, and the tau is not unique to Alzheimer's because it also occurs in these other diseases. And ubiquitin frontotemporal, I worked at TDP43, that was really what I published on for the last 10 years, and alpha-synuclein, obviously, in Parkinson's and diffuse heavy body disease. So the proteins are different. That's just saying what I said before, the pre-set. I'm not going to go through it, I'll skip that if you don't mind. So we're going to look now at the transmitters and then amyloid and tau. So the first one that was noticed in the 70s, so quite a number of decades ago, showed that there was a deficiency of acetylcholine, and they thought, right, you've got it. This acetylcholine is made, and if you give it an ACH inhibitor, and you make more acetylcholine available to the postsynaptic site, where the patients are going to, but it's only a symptomatic benefit, and it's only mild to moderate disease. So really, we're looking at this, and certain parts of the midbrain had these deficiencies well documented long time ago. Glutamate is another one, and anybody who goes to raves as they do in Adelaide and takes these drugs, just remember that this is going to be bad news for you, because the NMDA receptors actually are mediated by calcium, and memantine is the drug that's used, and so you can use it in combination with donepezil, with Aricept, or you can use it on its own, but generally speaking, it's reserved in Australia, in America, for more advanced disease. And there it is, the little green molecule on the side that mops up calcium and corrects the NMDA mischief in the brain. So don't take ecstasy, otherwise you're going to get that. The amyloid hypothesis, well, there's normal amyloid in the brain, and there's abnormal amyloid in the brain. So if you look over here at this membrane, you will find over here that there's these fragments of A beta. And if you get alpha secretase on the left-hand side, you go through a normal pathway with normal amyloid. But if you get beta secretase, then this thing becomes an abnormal molecule, which forms a peptide, oligopeptide, and eventually a plaque. And this is the key feature, because as you get older, this is what happens to people, to all people. So amyloid plaques happen 10 to 20 to 30 years before cognitive decline, and A beta is clearly would affect therapy. If you could mop that up in an early enough stage, that would be great. But there are side effects of these trials. Vasogenic edema, some hemorrhages. So it's not exactly an innocuous drug, these monotonies. And of course, they cost you $16,000 annually, which would break budgets worldwide. It's got to be. Again, our work is to show you the plaques with the different stains, but that's well known to you. Those are the plaques we talked about there. And this is work from Bruce Miller's unit at the University of California, where he's showing the amyloid plaque and he's showing you the images that, and the three-dimensional, which is at the bottom of both the plaques and tangles, and showing you where the medial temporal lobes have the impact and sometimes the frontal lobes in these diseases. So these are PET scans, amyloid PET scans. There are more. So on the left there's A beta and there's tau, and those are people with multi-domain dementia, so there's strokes and all sorts of other things going on, and they call it Alzheimer's plus. And this one has really pure, so there's A beta, which is really the red stuff is bad news, and the tau, and then the functional image shows the waste is. So all three of those images are superimposed and give you nice clues. So the tau hypothesis is there are many different forms of tau. There's misfolding, and essentially the drugs are unimpressive in terms of their use. But it is a toxin to the nervous system, and there it is. There's what tau looks like. So those neurons become tombstones. They sort of ghosts. They used to be neurons, but they smashed, and there's the areas that they looked at. And there's our work again showing tau studies in our labs. Now, the most important slide for today is to look at why there is a gap. I mean, I've been in congresses over the last 20 years where they've been the tauologists and beta allergists. And they have war. I mean, they come to knows it needs to. And it's nonsense, because basically what's happening is that there's the A beta in the beta secretase, and it forms all sorts of things. It actually causes inflammation. It causes A beta aggregation. There's excitotoxic drugs that are used, excitotoxic mitochondria. And the tau is part of whether amyloid comes first and tau second is the material. Both occur together, go all the way down and interact with neurotransmitters and kill the nerve cells. That is from the New England Journal of Medicine. It's quite old. I'll give you the reference, I think somewhere, yes, somewhere it was 2006. So but it's a beautiful slide to show you. There was a Boston researcher that published this. Okay. So the underlying, just to repeat what I've said, aging enhances or reduces this clearance mechanism. So A beta is normally cleared by the macrophages and microglia in the brain. The tau tangles then accumulate, causing neuronal death. And there's a lot of skepticism because people are saying, oh, well, these monoclonal drugs don't work, and so it can't be. But as I pointed out, they're using the wrong population at the wrong time to test those drugs. And it could be exciting if we start identifying them early on. Now, I'm going to move on to some of the non-Alzheimer's, just for completeness' sake. And this is really my major interest. Alzheimer's, just I had to study this to understand how this all fitted in. So we worked on these corticobasal degenerations and the frontotemporal dementia syndromes. Before I go, there's a vascular hypothesis also that's come and gone. There's a viral hypothesis. And funny enough, right this week, somebody said from Stanford that there's a shingles vaccine, herpes vaccine that protects patients, maybe, against developing Alzheimer's. So viruses may well have some kind of role, but whatever it is, it's nothing compared to the stuff that I've talked about before. Okay, so we can compare in the last 5 minutes, we can compare Alzheimer's to frontotemporal dementias. And we can see the difference. This is Bill Seeley's work mainly. and I worked with him in pathology on the differences between Alzheimer's and frontotemporal dementia. And there are comparative things. I won't go into details, but it shows you that in frontotemporal dementia, it's mainly the cingulate gyrus of the limbic system, where memory is intact. Whereas in Alzheimer's, it's the memory and other things are reasonably okay to the advanced stage, where both diseases just clearly. And there's two types of frontotemporal dementia: the behavioral syndrome, and there's a language syndrome. And that's another talk, another hour. So there's the insulate, the behavioral variant anyway, and you can actually see that the temporal lobes are affected so badly. It's mainly the frontal lobes, and it's mainly the temporal medial lobe, and particularly things like the limbic system and the cingulate gyrus. Now, all the young people in this audience, this is the dinosaur that's giving you this presentation. I worked with this. Okay, cut this up and it's much more fun. Go and read Nature. Because they now are looking at the molecular levels in comparative brains that block problems at different stages. And if you concentrate on that panel, that's just showing you the areas of their sample. All right, so the middle one's the entorhinal cortex, the prefrontal in yellow. I'm going to blow that up and show you what happens with the lag in the diagnosis of this disease. And this is molecular level. So if you look at this carefully, you will see that, first of all, males and females, the type numbers are equal. So this shows nonsense. You can't do it. So Alzheimer's disease stage, the global pathology gets worse and worse and worse as the block stage goes from 1 to 6. All right? But the interesting thing is that nobody diagnoses dementia clinically at 1 to 3rd level down. No one diagnoses it in the early stages, the block 1 and 2. But everybody diagnoses it on the blocks. And sometimes they make mistakes. So in some of these things over here, new lines, they say there's no dementia. Now, of course, if you specialized clinics, they don't make that mistake as often. But again, with all due respect, you know, we as physicians will sometimes make mistakes, even when we shouldn't, when we actually think, because there's other things that look more like strokes and stuff, and we make a mistake. So that blue lines shouldn't be made mistakes with their diagnosis, because you're at the block stage where it's obvious that this is bad pathology of amyloid in the brain. And Brock's paper showed, but the mischief is that middle, where the blocks function between short-term memory and then laying down in the brain. Okay, so go away. Brock's paper then showed something many years ago, here we go, 2015, showed the amyloid increase in the brain. And these were people who didn't necessarily have diagnosis of Alzheimer's. And the tables parallel that. So as you get older, there's lots of detail on lots. Funny enough, for a long time, the pathologists noticed that the plaques correlated better with the clinical deterioration, whereas not the plaques, the tangles, the neurodegenerative tangles, correlated much better with the clinical symptom. Whereas the amyloid plaques, well, the wars went on for a long time. But I think that they resolved them. Better than that, they're actually able now to go into all the areas. I don't know if you know it, but there are 30 different nuclei in the nucleus accumbens. And they've been able to go right into all those little neuronal circuits and things. And some of them go to the thalamus, and some of them go to different parts of the brain. And they wander all over the place, because it's the body language part of language. So they've done all of this kind of thing, and they've worked out the astrocytes and the oligodendrocytes and stuff. So there's Nature, last one. Here's the reference. I've got it for you, Andre. I'll give it to you. I'm just going to look at it. I'll give it to you on this. Now, the most exciting advance, really, for me, has been the fact that there's a correlation between the PET scans that clearly show Alzheimer's and these p-tau 217. I've had no experience with Bruce Miller's stuff from recent publications. So those tau markers, in the CSF particularly, but it's easy in the blood as well, correlate well with the functional imaging of PET scans. Isn't that exciting? So we can do a blood test now, early on, diagnose these things. And then if you give them monoclonal antibodies at that stage, then you could tell me they don't work. But until they do, I don't believe them. So the blood tests show, and there it is, particularly the tau ones, the tau markers, show a 90% statistically very significant correlation with the PET scans. Amyloid less so. That's it. Thank you very much, and I've got lots of time for questions.